started. So I'm Alfred, I'm the next speaker, and I'm an associate professor in the Department of Medicine here at UTHSCSA, and I'm also a clinical investigator here at the Audio Murphy VA Hospital. And I recently relocated to San Antonio from Pittsburgh, where I was on faculty for 8 years prior to being there. One of my areas of interest is prognosis and kind of how it can be predicted and then utilized clinically, and that's going to be the topic of my talk today. So if we have two patients, who do we think has got a better prognosis out of these two individuals? So A, we have a 72-year-old man who has atrial fibrillation, congestive heart failure, chronic renal insufficiency with a creatinine of about 3.1, who's being discharged home from the hospital after having a mild stroke. Then we have B, we have a 75-year-old woman who has atrial fibrillation, coronary disease, hypertension, and diabetes, who's being discharged to a skilled nursing facility from the hospital after also having a stroke. She requires some assistance with bathing and dressing. So these two seem kind of pretty similar. They're about the same age. They've had similar medical problems. And they've both been in the hospital, but are they the same or are they different? So who would vote for A, having a better prognosis, meaning being less likely to die over some time span in the future? Who would vote for B? Okay, so we got 2 for B. We had 1, I think, over there for A. Okay, we got 1, 2, 3, 4, 5, 6. Okay, so it looks like kind of we go with A as the one here, and we'll get to the answers to this at the end. Okay, and now we have A or B for this pair. So we have A, the 71-year-old man who has mild cognitive impairment, lives alone. His daughter is very involved with his life as he needs some assistance with grocery shopping and heavy housework. He's able to travel from, or his ability to travel from the house is limited by claudication from peripheral vascular disease. And then we have B, a 93-year-old woman who lives alone, who drives, shops, and visits her grandchildren in a nearby city. She enjoys working in her yard in the summer. What do we think about these?
B.
Who has a better prognosis?
B.
So B. Okay, so let's see a show of hands. 1, 2, okay, looks like everyone's gone for B. So kind of everybody figures, oh, he must have made it such that B is going to be the winner here. But at the same time, you know, A is 71, 20 years younger. Anybody want to change their vote? Okay. So now we'll go to A or B for this pair. So here we have a 61-year-old man who has diabetes, compensated congestive heart failure, mild COPD, prostate cancer, coronary disease, and he's had a stent. He still works as an accountant. He drinks in moderation and smokes about a half pack of cigarettes per day. And then we have B, he's an 86-year-old man with hypertension, coronary disease, mild dementia. He needs some assistance with his finances, but otherwise he needs little assistance from his wife. He recently stopped driving after running over the mailbox. So what do we think about this pair?
B.
B again? Okay. Okay. So why would we want to estimate prognosis for a patient that we're seeing in a clinic or in a nursing home or in the inpatient setting? Anybody have any thoughts? Okay, influential planning care. What was that?
Treatment options.
Okay, so you might kind of think about different treatment options, maybe like, you know, elective surgery versus not elective surgery, maybe hospice versus not hospice. Okay. Okay. So here are a couple of things that I was thinking about. One is I think it kind of helps providers frame a patient. So like when I'm seeing a patient in clinic, I'm kind of attuned to these issues, and the reason is that I'm trying to get a sense to what the future is going to play out, so I can kind of anticipate what their care needs might be. Somebody who I think is closer to the end of life, those are going to be people that I'm going to be really aware of. Boy, you know, if something changes, you know, this this may happen really quickly, and I need to be very nimble and able to kind of see the person quickly, potentially change our plan of care pretty quickly. Think about, are they going to need a different level of care, those types of things, and I become more sensitive to those. Whereas it's somebody who's maybe younger, better prognosis, I'm kind of thinking about, if there's little bumps in the road, those may not have the same significance for that person as it may for someone who I think is closer to the end of life. Also, it helps me a little bit with treatment decisions. Often patients will kind of turn, I always do it's kind of your choice for where to go with treatment, but then a lot of times that gets kind of turned back either from the patient or from their caregivers onto me of what would you do if it was you? And so, one of the things I would think about would be like, okay, well, what is the estimated benefit for me? If we're talking about what to do about the knee osteoarthritis, if it's going to be a surgery that's going to involve a 6 to 12 month recovery, and the person only has a 2 to 3 year life expectancy, you might be asking them to give up half their life expectancy to lessen optimal quality of life. And so you may say, boy, using narcotic medications or other things to control that pain might be the better thing to do. Then on the other end of it is that we often think about prognosis as being a way of kind of limiting treatment choices. But sometimes it's also kind of pushed me that there are patients that I've been aware of. Well, this person actually got pretty good prognosis, and maybe it's now time to address that knee osteoarthritis. Have the knee replacement done. Now, because in the future the surgeons won't be as excited about them as a candidate for the surgery, and they're still going to have a fair amount of time they get benefit from that. And so this really, that addressing that knee pain or other symptom may really help that person in the short term, and then they have a long time to get a benefit from. The next one is, a lot of times we have kind of the screening decisions. Do we screen for colon cancer? Do we screen for breast cancer? And again, one of the big things with that comes down to how long do you think the person has as an estimated prognosis? If the person has a 1 to 2 life expectancy, going looking for a cancer may not necessarily be in that person's best interest. It may kind of lead them to go down having a lot of anxiety, go down the treatment pathway, treatments that are uncomfortable, and in the end, it's not necessarily going to help extend their life expectancy. Whereas you have somebody who has a longer life expectancy, then that colon cancer, that breast cancer, that prostate cancer may actually be a real factor during the rest of the lifespan. Somebody mentioned kind of decisions about aggressiveness of care. So it's like, do you do ICU, do you do hospice, do you do other things? Kind of in coordination with the patient and the family. And then also I'd like to think about a little bit kind of helping to plan for the future in terms of, should we start thinking about nursing home? Should we think about assisted living? And sometimes this can play a role in starting to think about what decisions we're going to make. So why would we not want to think about a patient's prognosis? Yes?
Well, I think at times you could run the danger of pigeonholing their future, kind of, assuming you know what's going to happen when they may buck the trend,
Right, exactly. Right, so you're exactly right, which is, anytime you're estimating, you're kind of playing the odds. So it's like when you go to Vegas, I'm like, well, I'm not going to hit on 20. At the same time, the next card may be an ace, and maybe it may be an 8 or something like that. You don't know what's going to be the next card in the deck. Yes. Other thoughts? Okay. Well, here's some of the thoughts I had, which is, so first one was, as you mentioned, the no scoring seems perfect. I think the next one really is that you need to be very careful about how do you talk to a patient about this. It's not, there are certain discussions that are very easy to have, like, I don't think you should be wearing your seatbelt when you're driving in the car. That's kind of one of those ones that, like, even if your patient doesn't want to wear the seatbelt, they're not really going to get upset with you by reminding them that they should wear a seatbelt. At the same time, this is one, kind of getting into the whole idea of prognosis that can really change your relationship with the patient in a bad way if you kind of bring this up and it doesn't go over very well. And patients often kind of break into different groups. There are some people that really do want to have a complete picture of what the kind of what the vision of the future looks like, and there are others who are kind of really take things more kind of by the seat of their pants, and the idea that people are thinking about what's going on in their health kind of upsets them. And then the other thing, of course, is we always need to be very careful about respecting patient autonomy. Is that patients have the ability to make their own decisions, and it may be a decision. A lot of times it's decisions I don't necessarily agree with, but that's fine. And then similarly, they may make decisions that aren't necessarily congruent with their prognosis. And again, that's something we need to be very sensitive to and appreciative of. So how do we predict prognosis for a patient? And so at a really simplistic level, you can use population data. This is a page that I just literally scanned right out of a book called Health in the United States. It's actually put out by the government every year. And it's actually kind of an interesting book. It has the birth, your life expectancy at birth for different years. So, and it actually goes all the way back to the 1900s, which for those of you who go to the front, you see this, which is kind of interesting. If you were born in the year 1900, your life expectancy was about 47 years. So, which is something that I always find really staggering in a way, to think that, literally just a little over 100 years ago, somebody who's my age, I would be in geriatrics clinic, in that birth cohort. Whereas we can see kind of the rapid progress in increasing life expectancy that's happened since then. But the other thing they do is they look at if you're 65 or if you're 75, what's your remaining life expectancy. And so like in the year 2005, for example, for kind of all races, all genders, if you're 65 years old, you have about an 18-year life expectancy at age 65. And if you're 75 years of age, you have about a 12-year life expectancy left. So I find that that's often a good, for me clinically, is helpful for me to kind of have a ballpark estimate. If I see a 65-year-old in my clinic, they have around an 18-year life expectancy. So that means things like cancer screening, all kinds of treatments are all totally appropriate for those kinds of patients. If somebody's 75, even things like cancer screening and lots of aggressive treatments are still appropriate things to do because they still have a fair amount of life expectancy ahead of them. Now, does anybody see a flaw in using kind of this life table approach?
It doesn't take into consideration other medical conditions or what's different about that particular 75-year-old than someone else.
Exactly. So you're exactly right, which is that it's not a manufacturing line, and so your 65-year-old 2 o'clock patients here, kind of anything could happen when you go out to see that person. And so yeah, that's kind of playing the averages. So this is like if you have 10,000 65-year-olds, you're going to have this 18.7-year life expectancy. If you have one, they may kind of have a whole range of different things. And so it was kind of they already started to get into some of the differences that we have among patients. So for example, they've been sensitive to the fact that patients come in males and females, and we can see there's actually a difference in life expectancy based upon which gender you are, with women tending to have a better prognosis than men do. And similarly, in this table, they've appreciated that patients come in different ethnicities, and they also kind of break that out based upon that. But as you brought up, patients come in more flavors than just genders and ethnicities. There's a whole slew of kind of what's happened during that 65 years that's being totally lost in this table. So kind of as we talked about, using the table approach really ignores important individual differences with regards to illnesses. It also ignores differences in the effects of age and illness on patient function, and it also ignores things like health-related behaviors. If you're a 65-year-old and you've been smoking since the age of 10, you may be a little different than somebody who hasn't smoked at all. So one way to get at this, there's been a lot of research done, and a lot of it was done at UCSF around the time that I was a fellow there and then briefly on faculty before I moved to Pittsburgh. And they started developing things called prognostic indexes. And these are things that have become very kind of hot and trendy in the world of clinical medicine right now. And kind of what they do is they use criteria that you can generate either by reviewing a patient's medical record or examining the patient or taking a history from the patient to then generate a score. And then importantly, you can convert that score to a risk. And the important thing about this distinct is a lot of times when we read a newspaper story about a article, or we see an article in a journal, you know, it'll be something like, well, does alcohol use correlate with osteoarthritis? And it will say, you know, somebody who's 65 years old drinks alcohol more than 2 drinks a day, they have a relative risk of developing osteoarthritis of 1.12 with a p-value of less than 0.05. So you're kind of like, oh, okay, you know, statistically significant association between alcohol use and developing osteoarthritis. The problem becomes like, how do you explain that to a patient, or explain it to yourself about, you know, what really is the risk of developing osteoarthritis if you're an alcohol user? So you can kind of look at it and go, okay, relative risk 1.12. That means you have a 12% increased risk if you drink alcohol. The problem is if somebody was telling me you have a 12% increased risk if you drink more than 2 drinks a day of developing osteoarthritis, my next question would be like, well, what's my risk of developing osteoarthritis? You know, if my risk is 0% or 2%, then having a 12% increased risk over 0% is still not going to happen. At the same time, if I have a 100% chance of developing osteoarthritis, well, you know, 12% of that doesn't really matter. It's kind of, you know, let's get out the bottle opener at that point. And so the nice thing about these prognostic indexes is they actually turn into a risk score and then into a probability, which is one that's very easy for at least me to kind of wrap my mind around. And then importantly, that risk is something I can tell a patient. Because often what that does is it gives you a 12% risk, but that's an absolute 12% risk. So that means you can say you have a 1 in 8 chance of this happening, or you have a 50% chance of this happening. And so it becomes a lot more conceptually easy than just saying, well, you have a greater risk than if you don't do something. It says this is what the absolute risk is if you do this or don't do it. And so importantly what this does is it facilitates the use in clinical settings, which is why this has become very popular. And then additionally it does is it allows the weighting of individual risk factors. So you can kind of also tease out, you know, what would happen if somebody changed their behavior, or what happens if they have a certain risk factor to their overall risk. Can anybody think of an example that they may have run across of a prognostic factor or prognostic index? So, So one of them that's out there that people use a lot is, like, for example, predicting the risk of stroke in people that have atrial fibrillation. So there's a thing called the Chads2 Index, for example, that looks at, do you have diabetes, do you have congestive heart failure, have you had a prior stroke, and some other risk factors, and it allows you to actually tell a patient, you know, you have atrial fibrillation, you have a 5% chance per year of having a stroke. And so it becomes very easy to explain that to a patient, because now it's like, okay, in any given year you have a 5% chance of having a stroke in that given year. And so it's a lot easier than saying, well, you have a 2-fold increased risk of having a stroke compared to somebody that doesn't have atrial fibrillation in your risk factors. Because, you know, you're always left with, like, what is the underlying risk? Whereas now this tells you, you know, it is 5%. So one of the first papers that came out on this was a paper by Louise Walter and others that was published in JAMA. And what they did is they developed and validated a prognostic index for 1-year mortality for older folks after hospitalization. And so they used data from 2 studies of hospitalized elders that had a year of follow-up. They looked at variables that you could identify at discharge of that patient to home or nursing home afterwards that would then subsequently predict outcome. And importantly, in this study, all the patients are over 7 years of age. So it's not necessarily going to be relevant for people who are younger than that. So what kind of risk factors do they identify in their study? And this is one where it may not project very well, but we'll go over it. They identified male sex as a risk factor. And importantly with this is what they have here is they have the odds ratio. And then importantly, they have how this converts into our prognostic index with points. So they have male sex, ADL dependency of discharge, and what this is things like, can you take a shower by yourself, can you bathe by yourself, can you eat by yourself, can you be dressed, those type of things. And often the way I think about it is of these, usually eating is the easiest of the ADLs, and so I kind of go, gee, did I see my patient eat breakfast when I went by to see them this morning? And then showering is usually the most complicated of it, and I kind of go, you know, if I was the nurse taking care of this patient, I would let that guy shower by himself or not, or this lady shower by herself or not, and that usually helps me figure out where in the spectrum they lie. They also identified a couple comorbid conditions, so the presence of congestive heart failure or the presence of cancer, and that led to the points associated with each of these. And then there were some laboratory values when the person was first admitted to the hospital, such as did they have renal sufficiency due to, as indicated by an elevated creatinine, or did they have a nutritional problem related to, shown by a decreased albumin level, and that also is associated with some points. So how does this correlate with prognosis? Well, the remarkable thing is, here's 12 months afterwards, and you can see if you had 0 to 1 point, you really had only about a 10% chance of dying in a year after you left the hospital. Whereas if you had 2 or 3 points, 4 to 6, or greater than 6 points, we can see, you know, how your prognosis really breaks out into separate survival curves, suggesting that they really are identifying things that are distinct about these groups of patients. And kind of the data going behind this is if you have 0 to 1 point, you have somewhere between a 4 to 13% chance of dying in the year after leaving the hospital. If you have 2 to 3 points, you're looking at kind of about 20% mortality, and then if you have 4 to 6 points, it's really about a 30% chance. And then if you get up to greater than 6 points, you're looking at almost a 60% chance of mortality in that year after leaving the hospital. And so you can imagine that if you had a patient that's kind of here, you're going to kind of think about them a little differently than if you're having somebody who's down here. The chances this person's going to have increased care needs over that next year is pretty high. And so this is going to be somebody that if you were developing an intervention to kind of really get them connected with social work, get them connected with home nursing, thinking about hospice, those types of decisions, these are the folks that you really want to go after. Whereas these folks up here, this is kind of somebody who's going to probably go back to having a more or less normal life after that hospital stay. Now, sometimes this is folks that were in the hospital. Now, most older folks are not in the hospital, and they live in the community, so wouldn't it be great if we had a way of being able to think about them in similar ways? And so this was a paper that was done by SIA14 et al., and this was also published in JAMA. And what they did is they developed and validated a Prognosis index for your mortality in older folks living in the community. And so they used a huge data set from a health and retirement study, and they had 4 years of follow-up. They looked at variables that you could identify at the beginning of that 4-year period that then would predict the outcome of living or dying at the end of that study. And this one, all patients are over 50 years of age. And so this is one that now becomes more relevant for broader swath of patients you would see in primary care. So what kind of risk factors did they identify in this study? So here they found that age, not surprisingly, played an important role in prognosis, where the younger you were, the better your prognosis was and the fewer points you got, you got more and more points. Again, male sex shows up again, so this is going to be kind of a recurrent theme for male sex. We see BMI here showing up, and interestingly, BMI at 25 is kind of, you know, when I go to the doctor, I'm being kind of yelled at for having a BMI of around 25. And so this is kind of saying if you're not a little on the chunky side and you're older, that's kind of a bad thing. Presence of diabetes, presence of cancer other than skin cancer, presence of lung disease, presence of heart failure, presence, history of smoking, and then interestingly, they found a couple of functional measures. So if you needed help taking a bath, that actually had a non-negative connotation. And interestingly, if you needed help taking a bath, that was really just as bad as having heart failure or lung disease or cancer. So it's kind of interesting in that this really indicates that there's something important we're learning about what we can and can't do. Similarly, if you had troubles doing your own finances, that also had just as negative connotations as having one of these diseases. If you had trouble walking a couple blocks, that also resulted in you getting points. And then interestingly, if you had trouble pushing or pulling a heavy object, which is things like moving around furniture in your living room, that also had points associated with it. And so how did this turn into a prognosis? Well, if you had 0 points, you have between a 0 and 1% chance of dying over a 4-year period. So really, if you come out with 0 points, you're in pretty good shape. If you get up to the point where you have 14 or more points, then you're looking at really around 60% mortality in 4 years. Or if you had 13 points, it's about 50%. So that kind of means that if you get to the point where you have 13 points, you really have about a 4-year life expectancy at that point. And so at that point, at least, a lot of people would start thinking things like cancer screening, for example, which is often thought to be a 5-year life expectancy, may not necessarily be the best thing to pursue in those types of folks. And then finally, oops, okay. So actually, the other thing that I thought was interesting about this, if we back up for a second, can anybody else think of a common disease in older folks that we don't see here as having a negative effect? Here's some memories.
Well, I don't see dementia on there, but it does ask about memory problems. A couple of questions.
Diabetes?
Okay. Yeah, so no diabetes.
Yeah,
Well, actually,
yeah, it's there.
diabetes
It's
right
right
here.
there.
Yeah, there's diabetes, but yeah, the dementia I think is really the main one that always comes to my mind. And essentially, where that kind of shows up is here.
Yeah, financing.
So what was interesting is that since I knew the authors, I asked them. I said, "Why didn't dementia show up on your thing? Was it just did no one have dementia in your study population, like they were excluded or something?" They're like, "Oh no, there were people that had dementia in the population, and they and in a single variate analysis, dementia did associate with mortality, but when they did the multivariate analysis, it always fell out." And the reason is these functional measures of finances and bathing took over at that point. So meaning it didn't really matter if you had mild dementia, if you're able to handle your own finances, or if you're able to take a bath by yourself. But if you had dementia and now you needed help with that, then it kind of indicated that your dementia was worse than somebody that was kind of mildly demented. And similarly, if you got to the point where you now needed help with doing your ADLs, it meant your dementia was even that much worse at that point. And so based upon the strength that those functional measures had, the same group, so Louise Walter and others from that same group was really interested in could we actually use functional measures all by itself to predict prognosis in people? Because that becomes really something that, if you have a clinic, for example, really just about anybody that works in the clinic can actually use a questionnaire to ask people about function, and it kind of gets out of having to think about all the comorbid illnesses, how severe the illness is it just a mention you have coronary disease, or is it real? It was now kind of just getting to what people need help with doing as a way of trying to predict what their prognosis might be. And so what they did here is they had data from one study with 2 years of follow-up, and they looked at variables in between this that predicted outcome. And this was for patients that were over the age of 70, and they specifically wanted to use functional measures as the variables here. So this was partly an experiment, and it was also one where, for applicability, it might actually be a potentially, might be the easiest thing to kind of implement because of the fact that you don't need a lot of specialist training to be able to measure these things. So the things they identified in this study was, again, male gender popped up as being associated with mortality, and gave points with that. Age, again, showed up as a risk factor, and you get more points the older you are. And then, interestingly, bathing showed up again. If you needed help with shopping for groceries, for example, that also gave you points. This difficulty in walking several blocks shows up. And then this difficulty pulling heavy objects shows up at the end. And so kind of how does this correlate with prognosis? You get 0 to 2 points, again, you kind of have a between the 3 and 5 chance, 3 and 5% chance of dying over a 2-year period. You get 3 to 6 points, now you're kind of talking about a 10% chance of 2-year mortality. And if you get more than 7 points, you're looking at almost a 1/3 chance of dying over a 2-year period. So again, we're able to kind of break people into different groups, really just by how old you are you male or not, and then what kinds of things do you need help with doing. And then finally, they also wanted to look at folks who are kind of at the end of life. And so these are a lot of patients that I tend to see in clinic. These are community living frail individuals who have long-term care needs. And this was using data from PACE sites, which is a innovative program as a way of trying to keep older people who could be in a nursing home in the community, often with the involvement of a very dedicated family and a PACE program site. And they looked at variables that, at PACE enrollment that predicted the outcome. And this was folks that were all PACE eligible, and they were 79 years of age. And just to give you a sense of what these types of folks look like, these are folks that, if you look at bathing, for example, really a minority of them are independent of being able to do that, and most of them need some degree of help with bathing, for example, and a good number of them are actually completely dependent and need help with that. Similarly, kind of the numbers are very similar for toileting, transferring, and doing really other basic things. And so what kinds of risk factors did they identify in this study? Again, they found male sex is kind of showing up as a negative risk factor for mortality. Age, again, shows up as a risk factor. If you need help with toileting, that also had negative connotations. If you needed help with dressing, if you had a history of malignant cancer, if you have heart failure, COPD, or renal failure, that showed up as, again, as negative risk factors. And so how did this translate into prognosis? In this study, if you had 0 to 3 points, it was about 6% 1-year mortality, whereas if you had greater than 5 points, you're looking at about 20% 1-year mortality. And in 3 years, it was really like, this identified people that had about 3-year life expectancy. So kind of to step back and say, well, okay, what kinds of things could we take away from this? That, if we're seeing a patient, or what kinds of things should we be attuned to that might suggest who's in a higher or lower risk category? As we can see, a couple of these identified age. So obviously, people who are older tend to have a poorer prognosis than people who are younger. Male sex, example, showed up a lot. ADL dependency showed up a lot. And so, for example, one of the things that residents are always getting mad at me for is I'm asking people like, oh, did you ask about people's ADL capabilities? And part of that is we just want to know about it for, like, do they need referral for additional help? And then also it has negative connotations with the prognosis, and so it helps us kind of think about where is this person on the spectrum. Additionally, some of the other things that showed up commonly were this having troubles with finances, shopping, being able to move objects, which probably is a measure of strength and balance. Diseases such as CHF, cancer, diabetes, renal insufficiency, lung disease, again, kind of showed up multiple times. So how would you put this into practice? And one of my thoughts on this is before I do any kind of test, I always try to decide how's the information going to help me. So is there a specific clinical question I want to try to address? And it might be something simple as, should I consider referring this person for a certain elective surgery? Should I consider sending this person for a colonoscopy? Or, what are my expectations for care needs for the next couple of years for this person to help me plan going forward with this person? How pressing is it for me to start thinking about their advanced directives and kind of their end-of-life planning? Is this something that I can wait to develop a lot of rapport with them, or is this something I need to kind of start doing earlier on? The next thing is to try to pick the right index, and so this would be, and we talked about indexes, for example, that specifically were applicable to PACE patients or to hospitalized patients. there's a website out there for those of you that want to put this into practice called Prognosis. That if you search for this on Google, you'll bring it up. And the great thing is they actually have calculators right there on the website that you can put data into and get a prognosis for that patient in real time. And so it's something that if you're in clinic and have a smartphone or have a website or have web access or anything, it's a very easy thing to do. And it's something we've actually done sometimes. We had a patient that we were debating about, you know, what should we do for colon cancer screening for this person. We were able to actually go through and estimate what this person's prognosis was using this website. The other thing to always be careful of is make sure they don't have a condition that may supersede the index. The problem with these indexes is that often they didn't have tons of patients that had really bad things going on that might override the rest of the data. So for example, an elderly ESRD patient who's on dialysis has about a 25% one-year mortality. So that's going to often blow a lot of things out of the water when you calculate the prognosis using the calculators. Similarly, an older patient who falls and breaks a hip, it often has about a 50% one-year mortality. So again, that would be one, if you kind of score them out using the discharge calculator, you might get a better prognosis than you would because of the fact that they were in the hospital for a very specific reason that has unrelated connotations. The next step is then to gather your data, and then your last thing is to kind of calculate your score and your prognosis at that point. And this is that ePrognosis website, and this is kind of a screenshot from it. But I think this is a really wonderful resource that if you're trying to put this in practice, or you use it to help you, so that you can actually just get this right off of the web. So let's get back to our cases here. So for the first one, we picked A, who was a 71-year-old man with mild cognitive impairment. So if we calculated the prognosis for these folks, we come here, for example, and use, skip this slide. Next one. Here we go. So this is number one. So this guy, we picked A, which is a 72-year-old man who's being discharged home after the embolic stroke. So these folks are being discharged from the hospital, so we can use the hospital discharge calculator. And so for the A, person's male, has congestive heart failure, and has chronic insufficiency of creatinine greater than 3. So that gives us a total of 5 points. On the other hand, our lady, she has some ADL dependency, which is dependent on 1 to 4 ADLs, and she gets 2 points for that. So he has about 30% one-year mortality, or she has more like a 20% one-year mortality. So B1 in this case. If we go to our second one, we had A or B for this one. For number 2, we picked B, who's a 93-year-old lady. And so this is one we both live in the community, so we can use the community calculator for this one. He gets 2 points for being male, gets 2 points for needing help with shopping, 2 points for not being able to walk several blocks, and then we also get 1 point for having problems with moving heavy objects. So that gives us a total of 7, and that then gives us about a 30% 2-year mortality for this person. On the other hand, our 93-year-old lady, she's over 85, gets 2 points for that, but otherwise she's completely functional. And so that gives us about a 3% 2-year mortality for this person. So we were right in this one. And then our last one was, and this was number 3. Here we went with B, the 86-year-old. So for these, if we calculate here, we get 1 point for being age 60 to 64. We get 2 points for being male. We get 1 point for diabetes. We get 2 points for his history of cancer. We get 2 points for his history of congestive heart failure, and 2 points for his history of smoking. Gives us a total of 10 points. And that gives us about a 27-28% 4-year mortality. Importantly, if he quit smoking, for example, that would actually drop his prognosis down to really only having about a 19 to 20% 4-year mortality. Our 86-year-old gets 7 points for being over the age of 85, gets 2 points for being male again, 2 points for having troubles with finance gives us a total of 11 points, and that gives us about a 43 to 45% four-year mortality. So that one we picked the wrong answer for this one. Importantly, if this person decided to start smoking, that would increase the prognosis by about, or worsen the prognosis by about another 10%. So at this point, I'm just going to wrap up. So I think that predicting a patient's prognosis can be very helpful in clinical practice in terms of things that can help you with how aggressive or not aggressive you would care, and anticipating future care needs, and also just being able to help counsel the patient and family with kind of where things are going. There are individual differences that make estimating on age alone less helpful. And so this is something we see a lot in our practice, where we have patients who are in their 70s who often have a lot of medical problems, whereas we have people in their 80s and 90s who are actually fairly healthy. And we often spend a lot of time kind of counseling often either other healthcare providers about kind of the differences between some of our more robust and more frail patients in our practice. And then importantly, there are some indices that are available that can help provide useful estimates for trying to put this into your clinical practice. So at this point, I'll wrap up and take any questions.